Welcome to the deep dive. We're really thrilled you could join us today. If you're someone who loves pulling back the curtain on how the world works, you are in the exact right place.
Absolutely. The exact right place.
Today, we're embarking on a mission that it feels incredibly relevant to absolutely every single person listening. We are looking at a really fascinating excerpt from Paul Rutter's work.
Specifically his chapter on clinical reasoning.
Right. And our goal for this deep dive is to look under the hood of how healthcare professionals actually think. We're going to explore how they diagnose you, how they process that chaotic story you tell them, and crucially, why they sometimes get it wrong.
Yeah, the getting it wrong part it's a huge piece of this.
It is. And to kick things off, I want to hook you with a statistic from the source material that, it genuinely made my jaw drop when I read it. When you visit a clinician, diagnostic errors occur in 10% to 15% of consultations.
Yeah. It is a staggering number when you hear it out loud.
More than 1 in 10.
Right. And just to put some parameters around that 10 to 15%, it includes wrong diagnoses, delayed diagnoses, or just missed diagnoses entirely.
Wow.
And to understand why that happens, we first really need to define what clinical reasoning actually is.
Okay, let's start there.
At its core, clinical reasoning is the complex, dynamic cognitive process that clinicians use to collect, process, and then interpret your information to make diagnostic decisions.
So it's like the operating system running in your doctor's brain.
Exactly. It's the operating system. And this deep dive is going to equip you with a fundamental understanding of how that system functions the very moment you walk into the exam room.
I want to focus on that 10 to 15% error rate for a second, though, because as a patient, you sort of assume the doctor's office is this place of absolute scientific precision.
Right. You think it's just pure data.
Yeah. You go in, you hand over your symptoms like data points, and they output the correct answer. The idea that more than 1 in 10 visits involves some kind of error it's unsettling. What is the flaw in the machine here? Why is that error rate so high?
Well, the flaw in the machine is the human element. I mean, doctors are human beings operating under immense cognitive load.
And time constraints, I imagine.
Huge time constraints. A 15-minute appointment window forces the brain to use mental shortcuts to process information efficiently. Those shortcuts are totally necessary for survival in a busy clinic, but they make clinicians incredibly vulnerable to cognitive biases.
Okay, so the brain is basically trying to save time and energy.
Exactly. And the text highlights 3 specific biases that drive a huge portion of these diagnostic errors. Understanding them is crucial.
What's the first one?
The first one is called anchoring. This is a cognitive trap where there's an over-reliance on the very first piece of information the doctor hears or sees.
Okay, let me see if I have this right. So if I walk into the clinic and complain that my lower back has been killing me, and I mention, oh, I spent the weekend moving heavy furniture.
The doctor's brain immediately drops an anchor on muscle strain.
Right. So even if I mention maybe 5 minutes later that I also have a slight fever and it burns when I use the bathroom, they might completely gloss over the possibility of a kidney infection.
Because they are already married to the heavy lifting story.
Yes.
That is a textbook example of anchoring.
That is wild.
The initial piece of data, the heavy lifting, it sets the narrative. Every subsequent symptom is unconsciously weighed against that initial anchor. If the new information doesn't fit the muscle strain theory, the brain tends to discard it rather than tearing down the anchor and starting completely over.
Wow. Okay, so what's the second bias?
The second bias is equally common. It's called search satisficing.
Search satisficing.
Yeah. This describes the tendency to stop searching for an answer the exact second a fitting or plausible answer is found, rather than continuing to investigate to find the absolute best or truest answer.
I use a really similar logic when I lose my keys.
Oh, yeah.
Yeah, I tear the house apart, and the moment I find the spare key in a kitchen drawer, I completely stop looking for the main set. The immediate problem is solved, so the search is over. Even though the primary issue, my missing keys, remains completely unresolved.
That's a perfect analogy.
But it sounds like in a medical setting, if a doctor finds a plausible reason for, say, a chronic cough, like seasonal allergies, they just stop investigating. But that feels a little, I don't know, a little lazy when you're dealing with someone's health.
Well, it isn't necessarily laziness. It's often cognitive conservation.
Cognitive conservation. Okay.
Think about it. When a clinician is seeing their 30th patient of the day, finding a diagnosis that perfectly explains 80% of the symptoms offers this huge sense of relief. The brain literally rewards that discovery by shutting down the search engine. They are satisfied with the search. hence the term search satisficing.
But the danger there is obvious. The remaining 20% of unexplained symptoms might hold the key to a much more serious underlying condition.
Exactly, and that ties directly into the third bias mentioned in the text, which is confirmation bias.
I feel like we hear about this one all the time.
We do. Confirmation bias occurs when a clinician only looks for information that confirms what they already suspect, while actively ignoring, downplaying, or rationalizing away any symptoms that contradict their working theory.
Yeah, we see this in everyday life, especially with politics or news, but applying it to a doctor is terrifying.
It really is.
It reminds me of the classic WebMD trap that patients fall into. You have a headache, you look it up, you convince yourself you have some rare tropical disease, and then you only pay attention to the symptoms that match that disease.
You build a whole narrative around it.
Right. You're telling me doctors, despite all their years of medical school, do the exact same thing.
Medical training provides incredible knowledge, but it doesn't erase human psychology. I mean, if a doctor looks at your chart, sees a history of anxiety, and forms a preliminary theory that your chest palpitations are a panic attack, their questioning will subtly shift.
How so?
They'll ask leading questions that confirm anxiety, and they might inadvertently brush past your answers about, say, a family history of heart disease.
Wow. Okay.
Understanding these three biases, anchoring, search satisficing, and confirmation bias, it's incredibly empowering for you, the listener. It reveals the mechanics of miscommunication.
Because if you know a doctor might anchor to your first symptom, it fundamentally changes how you present your case.
Precisely.
It means you shouldn't bury your most severe or worrying symptom at the end of the appointment. You have to lead with it.
Yes. Lead with the most important thing.
That shifts the dynamic entirely. You're no longer just a passive patient. You have to actively manage how you deliver your own data.
You're part of the team.
Right. But assuming you deliver the data well, what is the doctor actually doing with it? The text mentions that a consultation begins with exploratory information gathering and something called cue acquisition.
Cue acquisition, yeah. They are listening, observing, and taking all this raw, chaotic information to build something called a problem representation.
Problem representation. What exactly is that?
The problem representation is arguably the most vital step in the entire diagnostic process. It is essentially a one-sentence summary constructed in the clinician's mind that highlights the defining, inescapable features of your case.
Just one sentence.
Just one sentence. Think about how a typical patient tells a story. They might talk for 5 minutes about what they ate on Tuesday, how their aunt also had a similar rash in 2018, and how the pain feels a bit like a pinched nerve they had in college.
It's a giant tangled ball of yarn.
Exactly. And the doctor's job is to pull a single, straight thread out of that mess.
Okay, so how do they build that single thread?
That thread, the problem representation, is built upon three critical pillars. The first pillar is the clinical context.
Clinical context.
This is the foundational background of who the patient is. It includes age, sex, and highly specific risk factors.
Like what?
Well, if a 20-year-old college athlete walks in with acute chest pain, the clinical context points in one direction. But if an 80-year-old with a 40-year history of smoking walks in with the exact same acute chest pain, the context completely changes the landscape of the problem.
The symptoms are identical, but the bodies experiencing them are so different that the medical translation is completely altered.
Precisely.
That makes perfect sense. So we have the clinical context as the foundation. What's the second pillar?
The second pillar is the temporal pattern of the illness.
The timeline.
Yes, the timeline. And doctors are listening very closely for specific keywords here. Is the issue acute, meaning it came on suddenly out of nowhere? Or is it chronic, meaning it's been simmering for months or years?
Okay, acute versus chronic.
Furthermore, is the condition stable or is it progressive and getting worse by the day?
I can see why the timeline is a pillar. An acute and progressive headache that started 3 hours ago and is getting worse by the minute, that sounds like a massive emergency compared to a chronic and stable headache someone has had on and off for 5 years.
The urgency is absolutely dictated by that temporal pattern.
Got it. And the third pillar?
Finally, the third pillar consists of the key symptoms and examination findings. These are the specific, localized details directly related to the main complaint.
So they take all three of those?
The doctor takes all three of these pillars and fuses them into a single cohesive medical sentence.
Can you give me an example of what that sounds like in their head?
Sure. In their head, they are forming something like, this is a 65-year-old male with a history of hypertension, presenting with acute, progressive shortness of breath, accompanied by a new wheeze.
Wow. That is a masterclass in filtering.
It really is an art form.
Translating a 10-minute rambling story into that tight three-part sentence really is the bedrock of everything that follows. I mean, if the problem representation is wrong, if they miss the fact that it's progressive, or they ignore a key risk factor, the resulting diagnosis doesn't stand a chance.
It falls apart entirely.
But let's assume the doctor nails the problem representation. How do they take that single sentence and turn it into a formal medical diagnosis?
This is where we enter the phase of hypothesis generation. Clinicians use a highly strategic framework known as the Murtaugh process to organize their thinking.
The Murtaugh process, M-U-R-T-A-G-H.
That's right. The Murtaugh process is brilliant because it actively fights against the cognitive biases we discussed earlier, specifically search satisficing.
Because it forces them to keep looking?
Exactly. It forces the clinician to categorize potential diagnoses into 3 distinct buckets.
Okay, what are the buckets?
Step 1, what is the most likely diagnosis? Step 2, what are the possible alternative diagnoses? And step 3, what are the critical, serious diagnoses that absolutely must be ruled out?
I see how that combats search satisficing. Even if the doctor finds a perfectly plausible answer for bucket number 1, the most likely diagnosis, the Murtaugh process, demands that they do not stop there.
They cannot stop.
They are mentally required to fill buckets 2 and 3 before making a final decision. But where do the answers come from? How do they know what goes into those buckets?
They draw from their mental illness scripts.
Illness script.
An illness script is essentially a mental filing cabinet of diseases. Through years of medical school, residency, and daily practice, doctors build incredibly detailed, highly organized files on hundreds of conditions.
Oh, I see.
When you present your problem representation, their brain is rapidly flipping through those mental files, looking for the script that best matches your presentation.
Let's ground this in a real-world scenario so we can see how the mental filing cabinet and the Murtaugh process work together. The source material provides a great, relatable example. The red eye. Imagine you wake up, you look in the mirror, and you have an acute unilateral red eye. Unilateral just meaning it's only happening in one eye.
Right.
You go to the clinic. The doctor builds your problem representation. Now, they apply the Murtaugh process and start pulling illness scripts. Walk us through that.
Let's walk through it.
Right.
Step 1 of the Murtaugh process. What are the most likely diagnoses? The clinician pulls the illness scripts for standard eye infections.
Like pink eye.
Exactly. The most likely culprit is bacterial conjunctivitis, which we commonly call pink eye. The script for that includes a sticky, gooey crust around the eye.
Gross, but very recognizable.
Very. Alternatively, it could be viral conjunctivitis, which typically presents with diffuse redness and very watery, tear-like secretions, rather than the sticky crust.
Okay, those both seem incredibly common and very manageable. So the doctor has filled the first bucket. Now they have to force themselves to look at step 2, the possible alternative diagnoses.
For alternative diagnoses, the clinician's brain might pull the script for a subconjunctival hemorrhage.
That sounds intimidating.
It sounds worse than it is. It's just a broken blood vessel in the surface of the eye. It looks dramatic and very red, but it's completely harmless.
Okay, good to know.
Another alternative might be the herpes simplex virus affecting the eye. These are entirely possible, though statistically less common than your standard bacterial or viral pink eye.
Right. Now we reach the most critical part of the framework. Step 3 of the Murtaugh process. Identifying the dangerous diagnoses that absolutely must be ruled out.
The scary stuff.
Yeah. If a doctor is looking at a patient with a red eye, how do they know if it's just a harmless broken blood vessel or something that could cause, permanent blindness?
They look for red flags.
Red flags.
In clinical reasoning, red flags are troublesome, severe, or worrying symptoms that suggest the patient is acutely ill or has an immediate complex issue that threatens their safety or function.
So they're the warning sirens.
Exactly. And when a clinician spots a red flag, the normal flow of the consultation abruptly stops. It triggers what the text refers to as a diagnostic pause, and almost always requires onward referral to a specialist.
A diagnostic pause. It's literally a mental brake pedal.
Yes.
Let's apply that brake pedal to our red eye scenario. What specific symptoms transform a frustrating but manageable pink eye into an absolute emergency?
In the case of an acute red eye, the critical red flags are decreased visual acuity, meaning the patient suddenly cannot see clearly out of that eye, and an irregular pupil.
An irregular pupil?
Yeah, where the dark center of the eye is no longer perfectly round. If you walk in with a red eye, but you also mention your vision is blurry and the doctor notices your pupil is misshapen, those specific signs immediately eliminate simple conjunctivitis.
The illness scripts for pink eye or a broken blood vessel just get completely thrown out the window.
They're entirely discarded. Those specific red flags point directly toward critical diagnoses that must be ruled out. Things like anterior uveitis, keratitis, or acute closed-angle glaucoma.
And to translate that from medical speak.
We're talking about deep, severe inflammations of the internal structures of the eye, or sudden, dangerous spikes in eye pressure.
Wow.
Conditions that can cause permanent, irreversible damage. Because those conditions are so complex, the clinician takes that diagnostic pause. They recognize this is beyond the scope of a standard outpatient clinic, which mandates an urgent, immediate referral to an ophthalmologist or an ER.
It's a beautifully logical progression when things are clear. You gather the cues, build the problem representation, pull the scripts, check for red flags, and make a decision.
When it works, it's seamless.
But human bodies rarely read the textbooks. Symptoms can be incredibly vague. What happens when a patient's problem representation doesn't neatly match any of the doctor's illness scripts? How do clinicians navigate that gray area of uncertainty?
Navigating clinical uncertainty requires a very deliberate, conscious shift in how the brain processes information. In cognitive psychology, there are two distinct modes of thinking.
Okay, let's break those down.
When a clinician is looking at a standard, obvious case like our sticky, crusty pink eye, they're utilizing type 1 thinking.
Type 1 thinking.
Type 1 thinking is fast, intuitive, and almost entirely automatic. It relies heavily on pattern recognition.
And to be fair, doctors have to use type 1 thinking for the vast majority of their day. I mean, if they spent 2 hours doing deep investigative medical research for every single stub toe or runny nose, the entire healthcare system would collapse by noon.
Exactly. Type 1 thinking is highly efficient. It is essential.
But I'm guessing it has a downside.
The danger arises when doctors try to apply fast, type 1 pattern recognition, to a case that is complex or uncertain. When the pieces don't fit perfectly, clinicians must deliberately force their brain to shift gears into type 2 thinking.
Type 2 thinking.
Type 2 thinking is the complete opposite. It's slow, highly analytical, deliberate, and resource-intensive.
So it's actual deep problem solving.
Yes. It requires them to consciously hit the brakes, question their initial assumptions, and methodically reason through the evidence step by step.
Asking a doctor who has been seeing patients for 10 hours straight to suddenly shift into high-gear, analytical type 2 thinking seems like a monumental task. The mental fatigue alone must be a massive barrier.
It is a huge barrier.
How do they safely manage a patient when they are in this state of uncertainty and fatigue?
The text highlights that this slower analytical phase is not meant to happen in isolation. It requires a collaborative management approach.
Collaborative with who?
The patient.
Exactly. When facing uncertainty, the clinician cannot just hand down a decree. The management plan must be formed in active collaboration with the patient. The doctor has to deliberately invite the patient into the process, taking into account the patient's own ideas, their specific concerns, and their expectations for treatment.
It becomes a negotiation rather than a one-way transaction.
Precisely.
And that collaboration is so crucial because, as we established right at the beginning, uncertainty is a permanent fixture in medicine. Diagnostic errors happen 10 to 15% of the time.
Because absolute certainty is often a myth, doctors have to have a fail-safe.
They need a backup plan. In clinical reasoning, this ultimate backup plan is known as safety netting.
Safety netting. I like that term.
The text describes safety netting as a non-negotiable essential part of practical prescribing and management. It is an explicit structural acknowledgement that the doctor's working diagnosis might be wrong or that the patient's condition might unexpectedly deteriorate.
As a patient, you generally assume that receiving a prescription or a treatment plan is the end of the line. You got the answer, you go home.
But it shouldn't be.
Right. Safety netting implies that leaving the office is just the beginning of a monitoring phase. What does effective safety netting actually look like? Because a doctor just waving goodbye and saying, "Call me if you feel worse," doesn't seem very safe.
A vague instruction to call if things change is entirely ineffective. According to the source material, proper safety netting is rigorous and must include 3 strict, highly specific components.
Okay, let's go through them. Number 1.
The first component is the expectation. The clinician must communicate exactly what they believe the problem is, and critically, The expected natural history of the illness.
The natural history. So if I bring my kid in with a nasty viral cough, the doctor needs to do more than just say it's a virus.
Right.
They need to tell me this is a virus, and the normal expectation is that the cough will likely sound much worse at night, and it is completely normal for this to last for the next 7 to 10 days. They're setting the baseline for what I should expect.
That baseline is vital. If they don't set it, you'll panic on day 3. Once the expectation is set, the clinician moves to the second rule, the warning signs.
Oh, warning signs.
The doctor must advise the patient on how they would know if the working diagnosis is actually incorrect or if complications are developing. This involves giving the patient very specific, objective worrying symptoms to monitor at home.
Continuing with the sick kid example, the warning signs would be the doctor saying, however, if your child suddenly spikes a fever over 103 degrees, or if you notice their ribs pulling in sharply when they breathe, that means my initial assessment might be wrong or the condition is worsening.
Exactly. You are actively teaching the patient how to spot the red flags in their own living room.
That is so practical.
And that leads directly to the third strict component, the action plan. You cannot just give a patient warning signs and leave them hanging.
What are they supposed to do with that fear?
Exactly. The clinician must provide explicit instructions on exactly what to do next if those warning signs appear. It could be instructions to return to the clinic for follow-up blood work, to call a specific specialist, or to go immediately to the emergency room.
The expectation, the warning signs, and the action plan.
Mhm.
I cannot overstate how much power this gives you, the listener.
It's a game changer.
If you're sitting in an exam room and the doctor hands you a prescription but fails to provide those 3 specific pieces of information, you now have the vocabulary to demand them.
You do.
You can literally pause the appointment and ask, before I leave, what is the normal timeline for this? What specific symptoms would tell me it's getting worse? And exactly where should I go if that happens?
And by asking those questions, you force the clinician to engage in type 2 thinking.
Oh, that's brilliant.
You're pushing them out of their automatic type 1 routine and ensuring that they have thoughtfully considered the alternatives. You transform yourself from a passive recipient of medical care into an active, protective participant in your own clinical reasoning process.
Looking at the entire landscape we've covered today, the mechanics of a medical diagnosis are incredibly complex and, frankly, a bit fragile.
They rely on a lot of moving parts.
We started with the reality of cognitive biases, how anchoring, search satisficing, and confirmation bias can derail a diagnosis before it even begins. We unpacked the art of the problem representation, seeing how doctors distill our rambling stories into a single sentence of clinical context, timeline, and symptoms.
We also explored the structured Murtaugh process, comparing that problem representation against mental illness scripts to identify likely, alternative, and critical diagnoses.
Right.
We saw how red flags mandate a sudden diagnostic pause, and we broke down the necessity of shifting gears between fast, intuitive type 1 thinking and slow, analytical type 2 thinking when uncertainty strikes.
And finally, we looked at safety netting as the ultimate fail-safe, the structured backup plan that acknowledges the inherent imperfections of medicine. We always like to leave you with a final, provocative thought to mull over long after this deep dive ends.
Consider this. Now that you understand, your doctor is actively trying to construct a precise problem representation while rapidly sorting through mental illness scripts during your short 15-minute window. How might this fundamentally change the way you prepare for your next medical visit?
Yeah.
What if, instead of waiting for the doctor to filter your story, you prepackaged your own clinical context and temporal pattern before you even stepped into the office? If you walk in and hand them the exact, organized pieces they need to build the right puzzle, could you actively reduce your own risk of falling into that 10 to 15% diagnostic error rate?
It completely flips the script on what it means to be a good patient. It isn't just about complying with orders, it's about knowing how to speak the language of the machine.
Absolutely.
Thank you so much for joining us on this deep dive into the fascinating world of clinical reasoning. We hope this knowledge empowers you the next time you find yourself sitting in an exam room. Keep learning, keep questioning, and we will catch you on the next one.